over 80 registrations for the session for today, and we have over 6 countries being represented. And so I think to get started, I would like to mention that this is the first time that we are running this meeting from Kenya today. And the aim is for us to decentralize this from South Africa and have future hubs all over sub-Saharan Africa to run these meetings. And I think this is the first time it's being held outside South Africa. So Kenya is probably one of the first hubs that we are looking forward to hosting this meeting. And we would love for others to take ownership as well in the future and to run these meetings from their side. So we've got 3 talks today. One is going to speak, Dr. Wangeshi Githaiga is going to speak about imaging for hepatocellular carcinoma. And that will be followed by 2 case presentations and discussions. So I think it is 4:34 South African time. And without further ado, I think we can get this meeting started. So I can open the floor to Dr. Wangeshi Githaiga. She's one of the radiologists working in Kenya, and she's going to give a talk on imaging for liver cancer. Thank you.
Good evening. I hope my slides are audible. My slides are visible and I'm audible. So today I'll be discussing about radiologic features of HCC and a brief talk about LIRADS. My name is Dr. Githaiga and my facilitator will be Dr. Odhiambo. So our outline would be a brief discussion about the general issues of LIRADS, which will entail a definition, when to use LIRADS and when not to use it, and CT and MRI diagnostic LIRADS imaging features. So during liver imaging, there are key questions one should ask themselves. The first question is there cirrhosis? The second question is there cirrhosis? And the third and most important question is there cirrhosis? So why is this important? Why is cirrhosis important? And it is important because it determines the differential diagnosis in liver lesions. So for instance, in this contrast-enhanced axial CT scan in late arterial phase, we see a heterogeneously enhancing a lesion in an antirotic liver with partial rim enhancement. And if there's no cirrhosis, a differential diagnosis usually is metastasis, hepatocellular adenoma, FNH, hemangioma, abscess, among others. However, in this patient who has a nodular liver surface suggestive of cirrhosis, the differential diagnosis is different. So the first thing we think about is a hepatocellular carcinoma, a regenerative nodule or a dysplastic nodule. We can also think about intrahepatic cholangiocarcinoma, and lower down on the list would be thinking about a hemangioma. So the key point is that cirrhosis stratifies the diagnosis. So we have a patient who has a 22 millimeter observation in the liver. This observation has diffuse arterial phase hyperenhancement in the arterial phase. In the portovenous phase, we see that it has washout, and in the delayed phase, we see that there's an enhancing capsule around it. So if this patient has a history of cirrhosis, diagnosis or differential diagnosis at the top would be hepatocellular carcinoma. However, if the patient does not have cirrhosis, differential diagnosis changes to adenoma as top on the list, foconodular hyperplasia, and lower down on the list would be thinking about HCC. So other stratifiers are usually sex, age, the older the age, obesity, diabetes, alcohol use, current or prior cancer, and pre-cirrhotic liver disease. So we have axial MRI images in various phases showing an observation within the liver. We see it has diffuse homogeneous enhancement, except for areas of scar tissue where it's non-enhancing. The lesion is seen to fade out in the portovenous phase, that is, it becomes isointense to the liver. On the delayed phases, we start to see that the regions of scar tissue that were not enhancing earlier are now enhancing in the delayed phases, and they become more prominent as the delayed phases are progresses. And this is usually a characteristic of conolgida FNH. This lesion sometimes has a popcorn appearance, as we can see here in the arterial phase. So these are zoomed in axial CT images of a liver showing a 6 centimeter observation. And we see that it has homogeneous arterial hyperenhancement, and it equilibrates in the portovenous phase. That is, it becomes isodense to the liver parenchyma, and that is usually known as fading and not washout. So in this patient who does not have cirrhosis, the differential diagnosis at the top would be for FNH, hepatocellular adenoma, or a regenerative nodule. However, if the patient had cirrhosis, top of the differential list would be HCC. So we have a 38-year-old woman presenting with abdominal pain. So we have an observation in an anti-cirrhotic liver that is hypointense in the pre-contrast study. However, as we go on in the contrast studies, we see that there is peripheral nodular discontinuous enhancement that has central pitot filling in the delayed phases. And this is usually characteristic of a hepatic hemangioma. So as radiologists, sometimes our reports can be terrible. They are confusing and non-beneficial to both the clinician and the patient. So sometimes we give conclusions such as indeterminate, equivocal, suspicious, clinical correlation recommended, cannot exclude cancer, and the like. So such ambiguous radiological reports are usually non-actionable, and the repercussions of this are enormous. So usually it leaves the clinician at a crossroads regarding further patient management. So because of that, a group of clinicians sat down and formulated the LIRADS lexicon, which is an adaptation of the BIRADS lexicon, and it usually means liver imaging, reporting, and data system. So it is a comprehensive system for standardizing the terminology, technique, interpretation, reporting, and data collection of liver observations in individuals who are at a high risk for HCC. It provides a standardized lexicon. It offers strict diagnostic criteria and has an easy to follow algorithm and reporting guidelines that improve the consistency and clarity of radiologists when they are reporting and interpreting in liver studies. So the process of conceptualizing the LIRAD system began in 2006, where an embryonic version was created. In 2008, an ACR LIRADS committee was launched. In 2011, the first version of LIRADS was released. And over the years, various updates have been released, with the latest being in 2018. So LIRADS addresses 5 imaging modalities, as we can see here, and 4 clinical contexts outlined at the top here. So when using ultrasound, it's mainly used for surveillance of individuals who are at a high risk of developing HCC. If you're using contrast-enhanced ultrasound, it's primarily used for diagnosis. Then these other 3 are used for diagnosis, staging, and assessment of treatment response, as we can see. But for the purpose of this lecture, we'll only look at the highlighted areas, that is diagnosis and staging. So the LIRADS diagnostic algorithm applies only to patients who are at a high risk of HCC, and these are usually adults with cirrhosis of most causes, patients who have chronic hepatitis B viral infection, or they have current or prior HCC. And this includes adult liver transplant candidates and recipients post-transplant. The LIRADS algorithm does not apply to children, that is people below 18 years of age, adults with vascular disorders such as Budd-Chiari, hereditary hemorrhagic telangiectasia, chronic portal vein occlusion or cardiac congestion, as such patients may have hyperplastic or hypervascular nodules that may resemble HCC, and this can give a false positive diagnosis. This algorithm is also not used in cirrhosis due to congenital hepatic fibrosis or a pre-cirrhotic liver disease unless it is due to chronic HBV. So this is the CT MRI LIRADS diagnostic algorithm, as we can see. It has two components. So there's a decision tree as outlined here, and there's the diagnostic table outlined. So the decision tree, as we shall see, is used when assigning an observation from LIRADS NC to LIRADS M. And then after that, we use the diagnostic table to categorize an observation either as LIRADS 3, 4, or 5. But we shall discuss that in further detail in the coming slides. So the first thing when using LIRADS is to identify an observation. An observation is usually defined as a focal abnormality in which is distinct from the background liver parenchyma. And once an observation is identified, the rest of the liver parenchyma is ignored and focus is given on the observation that you have identified. So we have an axial MRI image that shows a patient whose liver is very heterogeneous. However, we have a focal abnormality, which is highlighted, that was identified. So once an observation is identified, the next agenda is to characterize the observation, and there are 5 imaging features that are usually used. So we have AFI, washout, capsule, size, and growth. So AFI means arterial phase hyperenhancement, and this is defined as non-rim arterial enhancement of an observation that is unequivocally greater than the enhancement of the surrounding liver in the arterial phase. As we can see in this image, we have an observation that is enhancing non-rim compared to the rest of the liver. Then we have non-peripheral washout, and that is decrease in attenuation of the observation relative to the surrounding liver parenchyma, and this is seen in the portovenous or delayed phases when using an extracellular contrast agent, as seen in this image. The observation is hypo-intense to the rest of the liver. The next thing is a capsule, an enhancing capsule, and this is a smooth uniform rim of hyperenhancement around most or all of the observation, and this is seen towards the later phases. It's important to note that this does not pathologically represent a true capsule. So the next thing that characterizes an observation is the size. So this is defined as the largest dimension of an observation, and this usually includes the capsule. And this is measured in the phases where the observation is clearest, usually in the delayed phases or the portovenous phase. The other thing we look at is the threshold growth, which is 50% increase in the size of an observation in less than 6 months. So that is double the size in less than 6 months during follow-up imaging. So we'll go through the LIRADS algorithm in detail. So of importance when using the diagnostic algorithm, it's important to note that the observation has to be untreated. It should not be pathologically proven, and it should be in a patient who is at a high risk for HCC. So the first category is usually LRNC, which means LIRADS non-categorizable. And this is usually due to degradation of the image due to artifacts or omission of certain phases, thus rendering the study incomplete. So we have a contrast-enhanced axial MRI image that has a motion artifact due to respiration. So it's not possible to further characterize the highlighted observation due to the artifact. So in such instances, either you repeat the imaging or you have alternate imaging within 3 to 6 months. So once the quality and completeness of the study is ascertained, the liver is then evaluated for the presence of tumor in vein. And tumor in vein is defined as an enhancing soft tissue component within the lumen of the vein, regardless of an associated parenchymal mass. So for instance, in this axial contrast enhanced CT in the arterial phase, we see tumor within the main portal vein and the right portal vein in the arterial phase. So if you find tumor in vein, you assign the category regardless of any other lesion that you'll see or observation that you find. However, it's important if you're assessing Lyrad's TIV, you try and give the cause of the, if identifiable, you try and give the cause. So for instance, if you find an observation that represents HCC, you can say Lyrad's TIV, probably due to HCC. Or if you find an observation that is doesn't have characteristics of HCC, you can say, for instance, Lyrad's TIV due to a non-HCC malignancy. And the importance of assigning LR-TIV is that it's a contraindication to liver transplant because there's a likelihood of hematogenous metastasis. So once you found out that there is no tumor in vein, the features of the observation are analyzed to assess if the lesion is Lyrad's 1 or 2. And Lyrad's 1 is definitely benign and 2 is probably benign. The lesions usually assigned 1 and 2. 1 or 2 are usually cyst, a hemangioma, vascular anomaly, perfusion alteration, hypertrophic pseudomas, confluent hepatic fibrosis, or a focal scar. Additionally, if you have an observation that's less than 20 millimeters but does not have major features that we've described or ancillary features that we'll see, you still give it a Lyrad's 2. After that, the next category is Lyrad's M, and this is assigned to observations that are probably or definitely malignant but are not HCC specific. And some of these lesions usually have a targetoid appearance or an non-targetoid appearance. So usually a targetoid appearance has rim arterial phase hyperenhancement. It has peripheral washout. It has delayed central enhancement, and targetoid restriction. So targetoid reflects the pathophysiology of an HCC malignancy. Usually the periphery is arterialized and hypercellular, but you have a fibrotic or ischemic core, which enhances leads. So usually in the arterial phase, you have rim aphy, as you can see in these images, and then there's that peripheral washout. Then the center that is usually fibrotic enhances in the delayed phases. You have targetoid enhancement in the transitional phase or hepatobiliary phases, and you also have targetoid restriction. So the images at the bottom of the screen are all observations that show peripheral rim enhancement, but on biopsy, they were found to be very different. We can see that one was a cholangiocarcinoma, the other one was combined HCC cholangio, another was a sarcoma, lymphoma, and colon mets. So what are we trying to say? That if you assign a Lyrad's M lesion, it will definitely require biopsy to characterize it. So if all the above categories are excluded, after stepwise consideration, the diagnostic table is employed to assign an observation either Lyrad's 3, 4, or 5. So assigning of the Lyrad's is based on the major features that we've seen. That is non-rim aphy, the observational size, and the enhancing capsule, non-peripheral washout, and threshold growth. So the first thing usually is to determine if it has non-rim aphy or no aphy. After that, you determine the size, and then you count the additional features that it has, and then go to the table and decide where it falls once you cross-line the additional features. So we have an example of a lesion. So this is, an observation. It has non-rim aphy. As we can see, the observation measures 13 millimeters, so that would fall here. We don't see peripheral, non-peripheral washout, and you also don't see an enhancing capsule, so it has no additional features. So that would render it a Lyrad's 3. So we have another observation. So in the arterial phase, it shows no AFI. The observation measures 35 millimeters, so it would fall here. However, in the delayed phases, we see it has washout and enhancing capsule. Those are two additional features. So if you align it, it would be a LIRADS 4 lesion. So we have another example of a LIRADS 4. So it has arterial phase hyperenhancement. It measures 9 millimeters. It has a washout and a peripherally enhancing and an enhancing capsule. So those are two additional features, and that would render it a LIRADS 4. So this is a LIRADS 5 observation. It has a arterial non-rim AFI. It measures 18 millimeters, so that would fall here. We see it has non-peripheral washout and an enhancing capsule. So those are two additional features. So that would render the lesion LIRADS 5. This is another observation. It has a non-rim AFI. It is definitely greater than 20 millimeters. It has a washout and an enhancing capsule. So two additional features. That would be a LIRADS 5 lesion. So after you apply the LIRADS algorithm, there's the option of applying ancillary features. That is not compulsory, but it's an optional thing that you can do. So these are usually used at the discretion of the radiologist to improve detection, increase confidence, and to adjust the category that you've given. So you can either upgrade or downgrade an observation based on the ancillary features. So if you're upgrading the observation, you can only upgrade it up to LIRADS 4. So you can't upgrade an observation from LIRADS 4 to LIRADS 5. However, if you find ancillary features that favor benignity, you can downgrade the lesion from LIRADS 5 to 4 or 4 to 3 and the rest. However, if you find that you have one ancillary feature that favors malignancy and also an ancillary feature that favors benignity, don't adjust the category, so you leave it the way it is. Again, it's important to note that ancillary features do not adjust the category from LIRADS 4 to LIRADS 5. So this slide is just to emphasize the point that even if you have 10 ancillary features that favor malignancy, but only one feature that favors a benign lesion, do not adjust the category, just leave it as it is. So ancillary features are divided into two. You can have those that favor malignancy and those that favor benignity. And under those that favor malignancy, there are those that are not HCC specific and those that are HCC specific. And those include an enhancing capsule, a nodule in nodule appearance, a mosaic architecture, blood products in the mass, or if you have a fat in mass, more than that is in the adjacent liver. So the next step is a tie-breaking step. And this is usually applied if you have uncertainty about two categories. And this could be due to presence or absence of one or more imaging features that you had previously seen. So in such a case, you assign the LIRADS to the category that is of least certainty. So in such a case, if you're not sure if there's tumor in vein or not, you assign no tumor in vein. If you're not sure whether it's benign or not, you assign it to the LIRADS of least benignity. So if you're confused between 1 and 2, assign 2. Confused between 2 and 3, assign 3. However, if you're not sure if it is malignant, so you assign it to the least malignant LIRADS. So if you're not sure between LIRADS 5 and 4, you give it a 4, or you give it a LIRADS M and the rest. So a final check is done that ensures that the right category is assigned based on the best clinical judgment that we have seen. So if you're sure that the categorization is adequate, then your categorization is complete. However, if you're not certain, you can reevaluate the images or you can consult if you still have doubts. So this table shows recommendations that are given in terms of management of various lesions. So if you have LERADs non-categorizable, you either repeat the imaging or you have an alternative imaging that is done in 3 months. If you have LERADs 1 and 2, you continue 6 monthly surveillance, since these are already patients who usually undergo surveillance using an ultrasound every 6 months. If you find LERADs 3, you repeat the imaging or have an alternative imaging in 3 to 6 months. If you find LERADs M, 4, 5, or tumor in vein, multidisciplinary discussion is advised, and biopsy is recommended for tumor in vein, LERADs M and LERADs 4. Usually, if an observation is assigned LERADs 5, that's usually considered diagnostic of HCC. So no biopsy is advised for LERADs 5. So in summary, LERAD is a lexicon for liver lesions used in patients who have an increased risk of hepatocellular carcinoma, which aids in making the radiological reports actionable. So these are my references, and that's the end of my talk.
Okay, well, thank you so much, Dr. Githaiga. That was a fantastic talk. I think absolutely clear. I'm just wondering if there are any questions from anybody that that we would like to take. I think we can ask the audience to either raise their hands or put something in the chat box if they can't speak, or if they have any burning questions. But what I would like to ask, maybe as for starters, is regarding biopsying of liver lesions. So we often, working in tertiary level centers, have patients coming into us as referrals. You know, they've got imaging that's clearly a LERADs 5 tumor, which is undoubtedly an HCC, and yet you have a lot of patients coming in with biopsy results. Often someone has done a CT scan outside, a report has said biopsy recommended, and patients get biopsies and come to us. I'm just wondering if you have any sort of thoughts about that, and how we can maybe spread the word through forums like this for radiologists to try to avoid biopsying liver lesions unless it's decided at an MDT.
Yeah.
Of course, with the help of my consultants, usually when a lesion is assigned LERADs 5, no biopsy is recommended. However, I know most radiologists are hesitant to give it a LERADs 5, so they'd probably give it a 4 and below to facilitate biopsy. However, if you're sure that it's a LERADs 5, no biopsy is usually recommended.
Yeah, that's very well addressed, Dr. Githaiga. Now, the challenge is that you're able to make that call only if you have this background information that this patient has chronic liver disease, as cirrhosis, as hepatitis, or this patient has been treated before for HCC. Now, without that information, then you realize that associated to that is that even with very good CT, very good MR, sometimes that confidence that this patient has background liver cirrhosis, that information may be lacking. A few times we've been very confident. You see a lesion, actually we've discussed at the hepatobiliary meeting, large lesion, 3-4 centimeters, intense homogeneous enhancement, clear washout in the portovenous phase, and a capsule. So confidently, we looked at this lesion. Sorry. Yes, so we are very confident that this is HCC. But then we get additional information. This patient has been treated for sarcoma of the jaw. In fact, a biopsy confirmed this lesion, which looked very much like an HCC, was actually metastatic sarcoma. I remember the father of LERADs, I think his name is Professor Selim from the USA. He's the man who's done most of the work on LERADs. He's the original chair of the LERADs committee. And he said that no self-respecting metastasis will give you homogeneous contrast enhancement in the arterial phase if it is larger than 30 millimeters. Well, we've proven that that's not quite correct. So some in the absence of information about the background liver, you may still need a biopsy. But I would say that there's been a lot of positive development since we started organizing the hepatobiliary meeting in Nairobi. Thank you. Back to you, Dr. Karan.
Thank you very much, Dr. Odhiambo. So I think if there are no other burning questions, I see one in the chat box from Dr. Daniel Githaiga. He says, I'm not aware of the background of Laird's development, but I'm sure it was done in the West, where most lesions occur in the background of liver cirrhosis. How then do we extrapolate or adopt this nomenclature in third world countries where major lesions occur in non-cirrhotic livers, for example, in chronic hepatitis B virus patients?
Chronic hepatitis B is part of the list. So Dr. Hongeshi, you want to take that? Go ahead.
No, I was just going to add on to what you've just said. Chronic hepatitis B is one of the reasons why you can use Laird. So it is in fact one of the factors that you consider when you are applying a Laird's algorithm.
Okay, so it may have started in the West, but if there is any organization that has really made a major contribution to our understanding of imaging and oncology, it's the Laird's team that started off maybe in 2006 and gave us the first guidelines about 11 years ago, 2011. And these are applicable all over the world as long as you follow the rules. Maybe the only addition that I've seen from about 2018 is that contrast enhanced ultrasound has come back in a big way to address patients who are not where CT and MR are inconclusive. And it's quite surprising. There are a few times when you're not able to categorize on CT or MR, and yet on contrast enhanced ultrasound, the number one is that the cutoff size criterion is actually less. It's actually 10 millimeters. And when you've actually watched a few of the cases that are discussed, you realize that it's a very important addition to CT and MR.
Okay, thank you very much, Dr. Odhiambo and Dr. Githaiga. There's another comment here from Innocent Ikbaro. For tiebreakers, I'm just wondering the implications of TIV being given a lower grade, considering the implications in transplant. Why not the higher grade? Because if risk of transplanting someone with already vascular, because of risk of transplanting someone with already vascular involvement. So maybe one of the clinicians can answer that, because I think transplant is more of a clinical question, and the implications of tumor in veins.
Just disqualifies the patient from transplant.
Exactly, yeah.
So it's not that it's being given a lower grade, it's being given a different category. So the whole idea of standardization is to be able to give you an actionable report. That if we give you a certain, LRC, it means that you have to repeat. So every impression that is given is actionable. LRTIV means you're not going to transplant the patient. Thank you.
Yeah, I agree with that 100%. So I think we are almost 40 minutes into the meeting, and I think it's time for us to move to the case presentations from here going forward. So I would like to introduce Dr. Brian Misoi. Dr. Misoi is a young general surgeon, a very promising career ahead of him, and he's going to share with us one of the cases. I hope you can see my screen. I'd like to invite Dr. Misoi to start. Brian.
Thank you, Karan. Like he said, I'm Brian Misoi. I'm a general surgeon in Meru Mission Hospital, Maua Methodist Hospital. I'm just going to start my video. Okay, I hope you can hear me, Karan, and the rest. So our patient is
loud and clear.
Thank you. So our patient is a 63-year-old female. She's a housewife She doesn't have any significant social or family history, and she doesn't smoke or doesn't take alcohol. She has a previous history of treatment for hepatitis C in 2018 and stopped in 2020 after negative serology. During that time, she had upper GI bleed secondary to varices and had received banding in four different sessions. In 2021, endoscopy done showed she had all the varices eradicated. She had thrombocytopenia from that time. So thereafter, she has relatively been okay until recently when she's had epistaxis and bleeding from the mouth secondary to low platelet count. She's also had a recent hematemesis for which she had varices banded and the epistaxis managed conservatively. In terms of her medical history, there's not much other than a recent stopping of antihypertensive because when she became hypotensive. In terms of the physical examination, she was in fair general condition at the time we reviewed her. She was not pale or jaundiced. And on abdominal exam, she had no caput pedusae. There was an infraumbilical incision from a previous cesarean section. The abdomen was soft and non-tender. There was no masses or organomegaly, and there was mild ascites as evidenced by shifting dullness. At the time of assessment, she had a functional status of 1 based on ECOG, and her child-Pugh score based on the laboratory investigations at 7, which is a low B. She had a MEL score of 11, and those are her investigations at the time we saw her. Most importantly is the leukopenia and thrombocytopenia with the INR of 1.5. Her UNDs were normal with a normal total bilirubin and albumin of 35. That would give her Child-Pugh B with 7 as the score. She had a negative hepatitis B surface antigen, and hepatitis C as well was negative. Her alpha fetoprotein was 350. She has both CT and MRI, but we'll go through CT scans for this presentation. So the reason for the CT, she had a lesion picked up on ultrasound during screening. So we'll start with the pre-contrast scans. We'll just go directly to the abdominal sections. This is an axial CT. So you can begin to see the ascites around the liver with a shrunken liver and an irregular border. Then you can also see a large caudate lobe and a widened umbilical fissure. And also the spleen is enlarged. So if we can go to the arterial phase. So this is an axial view. Again, the arterial phase. We go to the liver. So as you're scrolling down, you can see the same features noted on the pre-contrast scan, but most importantly, I want to focus on the segment 3, where we noted a hyper-enhancing lesion. As you can see, this is arterial, so this is a non-rim arterial phase hyper-enhancement as well presented by Dr. Angeshi. And the lesion is about 1 centimeter from the measurements we obtained. Additionally, we saw a normal hepatic artery distribution. The rest of the abdominal scan on the arterial phase was normal. We can go to the portovenous phase. So in this phase, I want to highlight, first of all, the lesion. So if we can go to segment 3 where the lesion was. So we can see that there is washout. At that point, you can see the contrast has washed out during the portovenous phase. And then during this phase also, maybe you can demonstrate the collaterals, the collateralization, majorly perisplenic and also on the anterior abdominal wall, particularly lateral to the spleen. Yes, so there's collateralization secondary to the portal hypertension. In this, we can see that in this portovenous phase. If we go to the delayed phase,
I apologize, my computer is just frozen, so I can't. I'm trying to get us to the delayed phase. Just give me a second.
No problem. So if we were to go by Dr. Wangeshi's presentation, so far we have a 1 centimeter or 10 millimeter lesion that has already demonstrated arterial phase, non-rim enhancement, hyperenhancement, and there is washout during the portovenous phase. So we have two major criteria with about a 1 centimeter or 10 millimeter lesion that gives us a LIRAD 5. But we have a third major criteria as well, which you saw on the delayed phase, the rim enhancement, which would have been nice to demonstrate. But if we can't, it's okay.
Yeah, I think in the interest of time, let's just carry on because it seems to have frozen completely. I'm unable to get up the delayed phase imaging. I apologize.
It's okay, but he tells us that there was a capsule. Huh? So number
Yes.
one, you sound more of a radiologist than a surgeon. Keep it up. Number two is that the size is also important. Huh? So, and yes, so before you call it a LIRAD 5, you need to follow that, the decision table. Huh? Yes, so
Yes.
size is also an important criterion. And then you got two major factors. Okay.
Okay. Thank you.
And number three is that when there is a finding, you call it an observation, not a lesion. The reason this is important is that you also factor in, you also include pseudo lesions, false findings. Yeah.
Okay.
All right. And I think you made the emphasis that there's background liver cirrhosis.
Yeah.
Yes.
Yes.
There's even a right-sided, right lobe notch. So all those findings tell you there's background cirrhosis. So this patient fits in quite well. If the patient has hepatitis B, you don't need cirrhosis. That alone, you go ahead and use the LIRADs. I'll go to yes. But for hepatitis C, you need proof that there is evidence of chronic liver disease. Otherwise, I think you discussed it very well. Thank you.
Thank you, Prof. So coming from you, that's a high compliment. So if we can proceed, I don't know if Dr. Karan, you can still share the poll. We had planned to do a poll on.
We had planned to do a poll, but I think even that is not. It's not going to be possible at the moment. But maybe you can just ask the question.
Okay. So I'll just ask the question, and then maybe I'll give it 30 second pause before I continue to my discussion. So the question is, what would be the best management strategy? So just in summary, this is a 63-year-old female. She has a functional status of 1 based on ECOG, and she has child's PU B, low B, that is 7, with portal hypertension, and she has a peripheral segment 3, about 1 centimeter lesion that is LR5 on imaging. So my question is, what's the best management strategy? And we had 5 strategies that you would employ. You can think about them and then we'll discuss. So the first one is liver transplant. Second one is systemic therapy. Third one is ablation. Fourth is transarterial treatment. And the fifth is resection. So I'll give you about maybe 15 seconds to think about it, then I'll go on to my discussion.
I wonder if we have anyone who'd like to give any comments at this point in time. Any other hepatobiliary surgeons or medical oncologists, anybody with some insight or some comments as to what they would do?
Karan, we've got some fellows that are not so far from the exams on this side in South Africa. Maybe you could ask one of them. I see Dr. Mtimkulu is on, and also Dr. Rampai.
Okay, so let me go to Dr. Mtimkulu, Wanga, since I know him. So Wanga, any thoughts? What do you think of this lesion? And what do you think a good plan would be for managing this?
Hi, Dr. Thank you for the call. For the question. Yeah, given the size of the lesion, less than 2 centimeters, I would say this lesion would be best treated by ablation, but we know that doesn't always work very well. And also given the fact that the patient is child B, early, the other option would be for transplantation. But we know that service is also not widely available. So given the patient's fitness, I would opt for resection for this patient as my #1 strategy.
Okay, I think very valid comments. Just keep in mind that the patient has portal hypertension and has had 4 previous varicose bleeds. I mean, when we looked at the imaging, maybe we skipped through it a bit quickly, but there's not much of collateralization within the porta hepatis or around the area of the lesion. But do you think that having portal hypertension would change that decision for you? Or what do you think about that? Or maybe Brian should be asking these questions, not me. Sorry.
It's okay. I'd already alluded to some of those things, but I think the questions are well answered by Dr. Mtimkulu.
Yes, Dr. Gandhi, I think resection does make it a bit risky, having portal hypertension. And hence, I alluded to the fact that perhaps transplant would be something of valid option. But knowing that we don't have that service widely available, so that's why then resection would be something, of course, taking into consideration the liver volumes there of with the patient with the cirrhosis.
Karan, if I may comment, or Brian, if I may comment, it's Edward Jonas here from South Africa. I think the first thing that one has to say, we apply the Barcelona criteria that are very, very strict and very conservative, but this patient would fall sort of within the Barcelona criteria, definitely for transplantation, also for ablation, and maybe for surgery. There is an issue with portal hypertension and previous bleeds that's a little bit worrying. But I think the first thing we should say is this patient is for curative intended treatment. That would take any systemic therapy as the single treatment, or trans-arterial therapies would put that sort of a little bit further back. And I think then one can discuss the merits of different modalities. The transplantation, I think, is probably a good option in this patient if she would fulfill the criteria in terms of fitness and logistics for post-transplantation surveillance and anti-rejection drug administration and so forth. Also, ablation would be a good option, and for a lesion 1 centimeter big, the survival is probably as good as a resection if you do it properly. One problem that I can see in this patient, and I don't, maybe the radiologist can help us here as well, is there is proximity, if I remember the pictures of the stomach, and that makes it a little bit difficult with percutaneous ablation, because you're a little bit worried about collateral damage. So if you do it, maybe a laparoscopic approach would be preferable. But then when we do these and do the intraoperative ultrasound, because especially in the macroserotic livers, you're not sure which one actually is the lesion. And then it starts becoming a guessing game. And we do not have ultrasound contrast that is very valuable in that situation. So how do you manage that if you decided that ablation is the treatment of choice? What aids do we have to help us identify the lesion and not ablate a regenerative nodule next to the lesion?
I don't know if Brian wants to try and answer some of those, and then I can give my comments.
The last question, I'll hand it over to you, Dr. Karan, about what we can use. But I generally had the same idea about this patient. So basically, access would disqualify her for a liver transplant, although she would be a good candidate. She already has had significant liver dysfunction with underlying disease, that's hepatitis C and bleed, variceal bleed. And now she has a lesion that's less than a centimeter and single. It fits the criteria. If she would again meet the rest of the criteria that Prof. Edward had spoken about, the issues I would have thought about as well in terms of managing this patient is regarding the lesion. It's quite peripheral, meaning it's more accessible to limited resection. And again, a 1 centimeter lesion or less than a centimeter has been shown to have same outcomes with surgery and ablation, but still preference for surgery as it has less local recurrence. However, surgery would be generally contraindicated because of the portal hypertension. Again, if we go strictly via the Barcelona clinic, she is ECOG 1, which I think is a little bit too strict based on the Barcelona clinic, but puts her at an advanced stage, meaning she would then be planned for only systemic treatment. So just looking at the case, I thought maybe in our setup, the best approach would have been maybe surgery, and then second option would be ablation. But now I'd like you to answer the second question Prof. Edward had asked.
Yeah, thanks, Brian. That's a great discussion. I think you've captured all the valid points about this patient. It's quite a difficult situation. I had the same concerns about ablation percutaneously because of the proximity to the stomach. Although it is quite a peripheral lesion, we do have risk of thermal injury to the stomach, regardless of which modality of ablation that we use. I was wondering also, in terms of our intraoperative localization, we struggle quite a bit with that in our part of the world, because we have access to laparoscopy, but we don't have a laparoscopic ultrasound either. This lesion being peripheral, we may get lucky and we may just be able to see it on laparoscopy if we do it. And then that begs the question now, if we're there at laparoscopy and you have, for example, a harmonic scalpel with a small lesion like this, should you burn it or should you just resect it if you're there and you can actually see the lesion? But obviously the depth is another concern. So looking at the depth, we'd have to go deep enough and try not to cut into tumor if we're doing a laparoscopic resection. So it becomes quite tricky and challenging in those kind of cases. In terms of what else we can use, like Prof. Jonas said, we don't have contrast available. So in our center, we've recently got contrast for the ultrasounds, but it's still very much in its infancy. And having that in the intraoperative stages may be something in the near future, but we need an ultrasound probe as well at the same time. The other challenge I have with this patient is that her platelets are 43 at the moment, and she has had symptoms from that. She's had epistaxis recently. She's got a large spleen. So what do we do? Should we deal with the spleen first? Should we consider splenectomy for a patient like this so that the platelet count can increase? Should we deal with the hepatic tumor under platelet cover? Because I think interventional radiologists will also not be willing to puncture with a low platelet count like that. So should we do it under platelet cover with laparoscopy? Should we take out the spleen first? I don't have an answer. I'm just wondering if someone else may be able to offer some insight into that as well.
Hey, Karan. Hi, it's Sanju here. I just wanted to ask, what's the alpha-fetoprotein in this patient?
It's 350.
And the hepatitis C positive, not B positive, right?
It's C, fully treated, cured of hepatitis C. So there's no evidence of disease. Her viral load currently is undetectable since 2020.
I mean, the other argument one could make is, and I don't know if Prof. Jonas would agree with me, is maybe transarterial chemoembolization. I know it's quite a small lesion, but the liver is cirrhotic. And the reality is, are you going to do a liver resection and a liver like that?
Yeah, I thought just before you joined, Sanju, we said that this patient, barring the portal hypertension and the low platelets, would actually fulfill the criteria for transplantation, local ablation, and a resection. That because she would then fall in the curative intended sort of category, whereas systemic treatment and transarterial therapies, the intention would be palliation. So we were discussing these options. I mean, I think surgery, it's a very small resection, but we know that patients with portal hypertension in general do not very well. I was just wondering, Karan, we usually do not do splenectomies for these patients just for the low platelets. So I think she's in real trouble. I'm not sure how much that is going to help. It will probably make if it's gastric varices that bled, sometimes it can make a little bit of a difference. But I'm not sure it's going to do anything to the esophageal varices, and that is a big problem. So I would think it would be more appropriate to try to eradicate her. And in terms of just to get the bleeds under control. She actually bled gastrointestinally as well, or not?
Yeah, so she's had esophageal varices, banded 4 times in the past. The most recent was about 2 weeks ago. And she doesn't have huge varices anymore, but between 2020 and this year, she actually never bled. So initially in 2020, they thought that the varices were eradicated, but now I think because of the HCC coming up, there's been some decompensation, and she had another bleed.
So to come back just to the splenectomies, we would only do it as sort of a bailout of if we failed with sclerotherapy. We don't, or TIPS can't be done, or you don't have access to it, and then the splenectomy would be as part of a DVASC, a devascularization to try to. It's not treating the portal hypertension. It is it's basically making the likelihood of bleeding from varices less.
I was thinking more in terms of the consumptive nature of the spleen for the platelets, because I think that's what's responsible for dropping the platelet count. But I think this is something that can be done under platelet cover again. So I just wasn't sure if there's any benefit of doing the splenectomy. But again, with those huge collaterals around the spleen, there's a high risk of bleeding, even if we go and touch anything in that area as well. So it was just a consideration. But I hear you loud and clear. Okay, so I think we should conclude this case. It is the hour now since we started. I doubt we'll have time to discuss another case unless everyone is keen, but I think in the interest of time and respecting that people have attended here, maybe we should end with this case.
Karan, we can have the case for the next meeting.
Yeah, that'll be great.
We keep that in mind, and we always have cases at the end. So this was a really interesting case you had. So let's just reserve it for the next meeting. I think it's early in December.
I think that's perfect. That sounds good to me. So, any final words about what we should offer this patient? Should we do a laparoscopic ablation, or should we go ahead and just resect this laparoscopically? Transplant is definitely not in our armamentarium.
Yeah, I would, Karan, if I would argue in the MDT for doing an ablation and undercover, and you don't need to mobilize anything, so you're not going to cross any planes, you're not going to do any dissection. Lift the tumor from the stomach, and hopefully one can locate it. And with a 1 centimeter tumor, you can do a 2 to 3 centimeter ablation. And if you place your needle well, I think the outcome is likely to be quite good. I think that's the least traumatic for this patient.
Yeah, I think I tend to agree with that. Thank you very much. Unless Brian has any other questions or comments, or anyone else. I see 2 comments in the chat box. There's one question asking, is ablative therapy by radiofrequency or microwave ablation as an alternative to resection or transplant? At this level, transarterial punctures can be done with platelet cover. So I think that's what we've just discussed. That's the comment that Prof. Jonas has just made, that ablation is probably the best way and the least, I think with the least risk of any sort of complications. Brian, any further comments from your side?
No, thank you. Thank you for the good discussion.
Okay, so I think I'd like to conclude this session. We're 5 minutes past time, but I would really like to thank the speakers and the presenters very much. Thank you for your comments, and for those who also put comments in the chat box. We would not be able to have these meetings without ECHO from the University of New Mexico or the ECHO India team, so thank you very much to them. There is a feedback form available on the chat box, so if anyone's got some feedback, please be free to fill out the feedback form. The recordings of these presentations will be available on the Gastro Foundation website, and thank you very much to the Gastro Foundation for hosting us and for giving Team Kenya this opportunity to present some cases and to run this meeting. Thank you again to all the presenters, Dr. Githaiga, Dr. Alfred Odhiambo, who's facilitated this with his immense knowledge of wisdom. And thank you very much to Dr. Misoi. Thank you very much to Dr. Nyawira, who was supposed to present the next case, but you will have your chance at the next meeting. And thank you so much for the sponsors. Next week, the ECHO meeting will be on patient blood management, and we can share the invite and the links for all of those. Thank you very much.
Thank you, Team Kenya. Great meeting.
Thank you. Thank you.
Thank you, Chris.